So yeah, as I was saying, in the next 15 minutes, it'll be great to have your attention. I'd like to try and cover the topics of progress, partnership, and possibilities in the liver disease space. And of course, as all of you know, we're here because it's Connecticut Liver Health Day. I'm not sure how many of you know it is also National Amaretto Day. So we will be celebrating that this evening. So please all come back at midnight, and I will meet you here for National Amaretto Day celebrations. But moving ahead, so on the topic of progress, partnership, and possibilities, thinking about how to cover progress in hepatology, and there's been a tremendous amount of progress. I thought that an interesting way would be just to sort of really cover how progress is made and then just give you examples how that's happened in hepatology. So my favorite way that progress actually occurs is when it occurs through serendipity. And here are two of my favorite examples. In the 1920s, a bunch of people were studying the genetics of tumor control, which is appropriate considering what we just covered about HCC. And this was being done through grafting tumors in mice and F1 and F2 and working out the genetics. And as it happened, they actually were studying genetics. However, they were studying the genetics of tissue transplantation, although they didn't realize that. Okay, so George Snell realized that actually the loci, which are the MHC loci that we understand very well, were actually not controlling the control of tumors, but were controlling tissue transplantation. So this is, again, an example of serendipity. And then closer to home is, of course, the example of hepatitis B, where there was actually an investigation to try and identify minor blood antigens in the Caucasian population. And what they ended up doing was actually identifying the known antigens. So this is an octoroonly plate. A couple of patients and an individual with what they called Australia antigen. And this is a precipitant line that's formed through a phospholipid antigen and antibody through this interaction, which was known, and this was the unknown line, which actually is due to what they called Australia antigen, was the first indication there was something different. And they knew this was different because this was a protein antigen, whereas these were phospholipid antigens. The funny thing about this is that this figure is actually just sketched. They saw what they saw, they drew a sketch of it and submitted it, and it was accepted. So clearly journal criteria were quite different in the late 70s. Moving on to other forms of progress, obviously the vast majority of progress in history has happened through empiricism. And empiricism, unfortunately, gets a bad rap because we're sort of in this scientific state where if things are not hypothesis-driven, then empiricism is somewhat looked down upon. This is an example of empiricism. Twin brothers, Cosmas and Damien, who are in 300 AD, were well known for many healing interventions, including them was organ transplantation. And their pièce de résistance always used to be to take a limb from an African individual and transplant it to a Caucasian individual. And this is an example of bad empiricism, and I'll tell you why this is an example of bad empiricism. An example of good empiricism, of course, is the first attempt at homotransplantation in livers, which is this very famous paper right now. But I'd like to point out that, the survival was modest, to say the least. I mean, one patient died on the table, one survived 7.5 days, and one survived 22 days. However, between 1963 and currently, there have been massive advances in transplantation, okay? Massive, whether it's cyclosporin, FK, venous transplantation, cut down livers, living-related donor transplantation, huge, and also now it's moving on to extracorporeal perfusion to enhance survival of organs, mostly based on empiricism, okay? So there is good empiricism, and with good empiricism applied appropriately and expertly can lead to great progress. And I think we just need to recognize the value of empiricism. And just to come back to this was not bad empiricism because they tried to do an organ transplant or bad empiricism because it failed. It was bad empiricism because they didn't learn from it, right? So this painting was painted in the 15th century. So almost 1,000 years after this obviously must have failed, people were still celebrating its success. That was the bad portion of it, not trying and not failing, but not learning from it, okay? Other progress is made through technological advances. So this, of course, is familiar to you. This is just H&E light microscopy. And this was the hot technique in 1830. And because although lenses were around since about 1660, their quality didn't improve to the point where you could actually image sufficient area to do what we would recognize as histology. until Joseph Lister did this. And this, I wrote senior here because his son, who was also Joseph Lister, is much more famous. He was Joseph Lister of antisepsis fame. So clearly there was talent in the family. This is somewhat looks similar to this representation. So this is light microscopy. This image did not require either light or a microscope, okay? This is from basically scanning of digital barcodes, which are generated through messenger RNA-bound probes, obviously in liver tissue. So this is spatial transcriptomics. This image is actually from our own Ron Fang's lab using his in-house DBIT-seq technique. And the point is that this is now massively richer data set, and this is just one representation of this. This data set can just as easily be represented as a TSNE plot as this sort of pseudo-histological plot. So obviously, massive improvements in technological advances. I can't touch upon really any more of them based on the time. But as a concern or as something to be aware of is, this quote from Marshall McLuhan from the 1950s, and I'm actually quoting this out of context, but it still makes a point. He was actually speaking at that time about technological changes in the 1950s and not about science, but from the scientific aspect in terms of our technology shaping us is that we have to resist the temptation that we start asking questions that we can only answer with the technology that we have in hand. So technology can be seductive. We need to keep asking broad questions even if we only have the microscope to play with. So technological advances can obviously lead to progress. Let's look at the traditional scientific method, which everybody here, most people here I'm sure are familiar with, that we start with a question, a hypothesis, action and result. And this is a simple example. What causes MASH? Could it be TNF-alpha? Check TNF-alpha, and TNF-alpha is elevated. That would be considered a successful conclusion to a hypothesis-driven research. And again, extremely powerful. Obviously, it would be ridiculous for me to knock this approach, but just also keep in mind that pre-stating an association doesn't make it any more than an association, right? So even when it comes down to, predicting the roll of a dice, I think we would all get a squeak of pleasure if we call a 6 and it's a 6, okay? So pre-stating an association that's probabilistic, like rolling a die, doesn't make it any more real or anything less than a probabilistic association. And again, in hypothesis-driven research, we can get seduced by the fact that our idea came through, but again, until it's proven more rigorously, it is just an association. In the last slide, I gave you an example of omics, and this has dramatically changed the way we approach research, because these are the same 4 components that are up there, but the order has changed, okay? We still start with a question, but now, instead of coming in with a hypothesis, we do something. We check levels. Instead of checking the level of one RNA, we check levels of every RNA in the sample, right? And then perhaps we'll get just the same result, that TNF-alpha is elevated, and then lead to the hypothesis or idea that TNF-alpha is important. And this has had profound effects on biological research in the last 10 years. So first of all, pre-formulated ideas are not required to take an action, okay? Secondly, it's much more expensive. We sent off plasma for 80 samples from liver disease patients, and Olink proteomics cost us almost $100,000 on that. So I never needed to spend $100,000 on assaying 50, 60 biological samples. We may get unexpected positives, so we really have to understand our biology, and we cannot be boxed in and say, okay, I am a whatever person, I'm a bile acid person, or I'm a glucose person. You have to be like, I'm interested in the disease, and I will take wherever the data takes me. And that really is what this says, that there are unfamiliar territories that we have to be perfectly comfortable to step into. And then what has changed what has not changed is the logical framework. So the essence has not changed, although the way that we might order and organize this. And if I had time, I would show you, there are papers which have done omics work on normal livers and liver explants, and there's masses of data that's generated through single cell, single nucleus transcriptomic. We've learned almost nothing from that data, because the logical limits of an observation study, it's still an observation study, irrespective of how much data you generate from an observation study. So in some ways, a lot has changed. In other ways, really not much has changed. And currently, we have a hybrid system, which is okay as long as we recognize the limitations of each approach. Okay. Now, there's also commercial progress, and we have many folks here who have been instrumental in bringing the drugs that we use in our patients. And commercial progress is a whole separate area. I won't go through each aspect of this, but all the way from target identification to toxicology, IND application, phase 1, 2, and 3, FDA labeling, marketing, post-marketing monitoring, medical liaison, and I've missed half a dozen already out there, right? So this is a lot of, not a lot, a massive amount of work that happens that's often invisible to most of us. So at least we should recognize and we should acknowledge that this is happening, and without this, we won't be getting any drugs for our patients. And then, it's impossible not to mention that we are actually in the phase of non-human cognition, minus the consciousness part as far as we know. And this is, well, what is this? So again, this is a sort of a superlative type quote. We are undergoing a technological change for which there are no historical examples. Again, this is from McLuhan, but this is his quote from 1953. Okay, so I'm intentionally quoting him out of context because it makes a point. And the point is that, of course, there's always change, right? And in the 1950s, the change brought out by TV, radio, and the telephone, people were like going nuts about this. Like, what is this going to do to society, right? But so what I struggle with this fact that we now have non-human cognition is this change along the same level, or is this change at a level that's a whole different type of change that we've never seen before? And I think, fortunately or unfortunately, this is a change at a level that we've never seen before. This is not like what Marshall McLuhan was sort of struggling with in the 1950s. So, where are we and what should we expect? Let me just make sure, because no one's going to stop me, by the way, so I have to stop myself. Where are we and what we should expect? Well, we had an example of a patient with hepatocellular cancer, and this is a very simple example I made up. But unfortunately, we have many people like this. And obviously, it's a tragedy, right? Cancer is always a tragedy, but in someone as young as this, is particularly a tragedy. Now, if I was to ask you to imagine, can you imagine this being a common diagnosis, right? Not something that is an exceptional tragedy. Well, actually, we don't have to imagine that, because prior to 1970 in East Asia, it was a common diagnosis. You could walk into a hospital ward with 20 beds, and it would not be uncommon to see 1 or 2 young people with liver cancer, right, because of the vertical transmission of hepatitis B. So bad things happen, and things don't always just improve with time. And so the question is, in 2030, is it possible that this sort of a case will be a common diagnosis? And unfortunately, it is. Here I'm just showing you a paper from 2025. Up till 2020 is data. Okay, and again, the curve is not, or the line is not subtle. And beyond that are projections, and the darkest area are the most likely projections. And as you get into the lighter area, then the probability of those outcomes are less. So as you can see, it's not good, but you might well say, well, there is a finite probability that actually the curve will go in this direction and actually will decrease. So perhaps we shouldn't have all doom and gloom. This is data from 2 weeks ago in the New England Journal. Again, this is data, this is not projection. And this is data of type 2 diabetes in children between 15 and 19 years of age. And the curve is upward, okay? So this is data. It's worsening in teenagers, right? And so we know exactly what's going to happen when these people hit their 20s and 30s. These teenagers are going to be the 30-year-olds who we're going to see with liver cancer, okay? So that's really why we're here. This is really bad things are happening, and it's mostly silent, okay? So how effective are we at MASH at the moment? And keeping it simple, I think we're sort of at this point, really. We're not even at the half-full point. There are many aspects of progressing through prevalence, diagnosis, staging, and therapy. I won't go through each and individual one. You can briefly read. And I apologize about that I'm moving fast, but we have plenty of time to discuss later on. And the 2 areas we really need to jump on are diagnosis and therapy. So it's asymptomatic, it's high prevalence, no specific test. So anything to help with increasing the awareness of this disease, increasing the diagnosis of this stage. And we have some gaps in staging, but we can figure things out. And then, of course, therapy. We have 2 approved therapies. Both of them have an efficacy at 1 year significantly below 50%, okay? So we need to have improvement in that area because, that's not very good. So moving on to partnership. So, I've tried to represent, most groups that are present in this room, and apologies if I missed anybody. So I think most of you would fit into one of these categories. And, you've already heard of one example of partnership, which is that the state leadership, 2 representatives we have here, in June 2024, we created a MASH working group. They created a MASH working group, which I was privileged to participate in. And of course, it provided feedback, and then the state leadership enacted changes in the General Assembly, and that's really why we're here. That's why we have, Connecticut Liver Health Day. So we need to move ahead with this, okay? And, and it's actually unfortunate that you're all paying attention to me, because the answer is actually with all of you, right? I mean, because these relationships need to happen between the people, obviously all of you who are there. And I'll give you one example which hasn't happened yet, but I think has tremendous potential, which is that creating a common space where basic researchers in pharma and basic researchers in academia can actually communicate freely. I think if we can manage that, there's a tremendous amount of data sitting on both sides of the fence that we can leverage. So moving on to what we can do, possibilities. So here I'm putting up various websites, many of whom you are familiar with this, ASLD website, MELD website, Liver Talks website, etc. And then, of course, these are one example of practice guidelines. So all of us, many of us go to many of these websites, and it's somewhat fragmented. So one possibility actually is to create a hub which would bring all of this together. And I'd like to share with you what we've done so far. I will minimize this. So myself and some colleagues have created a liver hub, and I'll take you through some aspects of this in the next 3 to 4 minutes. And this is live, and you can just go on to ctliverhealth.org. So this will provide us with all the common calculators that we use, so we don't have to move between. No. Were any of the slides up there or none? Yeah. Okay. Sorry, it's on my screen, but for whatever reason, it's not there. Okay, thank you. So this is live currently, and you're all welcome to go to it, ctliverhealth.org, and I'm in the main site is such, and then there are various obviously tabs up here, and we've put multiple calculators that are in one place. Many of you are familiar with drug-induced liver injury, so you can put in whichever drug that you like, and it will give you information about the drug. It'll give you information about the R calculator. You can put in the basics and develop the RUCAM causality assessment score in here. We have multiple organizations that you would be interested in looking up, American Liver Foundation, etc. We also have links to press releases that pharma will be putting out in relation to liver disease. We will soon have a search function in this. Obviously, the journals that we typically go to, and then a couple of other things which are a little bit more developed are actually clinical trial guidelines. So, for example, one can put any particular drug, and it will show you all the clinical trial data that's available in that drug. I can't quite scroll down on here. So the trials, the different phases, what the data is for each trial, all in one place. And then finally, and there's more here that I can share with you, but this option actually lets you specifically ask questions from the guidelines only, okay? So many times we wish to stay within the limits of ASLD and EASL guidelines. So we can ask a question. The guideline documents are actually quite big. They can be 30, 40 pages long. So it can be difficult to find an answer within a 40-page guideline. This will take you to the guideline, and you can choose between ASLD and EASL. So I will stop there, and I don't think we really have a Q&A, but we can chat over the break. Thank you so much.